Increase your volume if you can a little bit.
You good?
Mm-hmm.
Starting?
Okay. How's that?
Sounds good.
Same days first.
Okay. Okay, so are we all here and ready to go? Okay, so I cannot, so you guys, I am sharing my screen, so I cannot see or hear anybody. So I'm going to have Dr. Kashani let me know if there's any questions in the
I'm
chat
here.
area.
Yeah, I'll give you any chats that is coming in.
Okay, so we're all good? Okay. So good morning, everybody. What I'd like to do is go over the changes that have occurred since the upgrade that we did on Friday. So some of this is cosmetic, but a lot of it, there's a few things that will actually affect you. So one of the first things, if you notice up here in the top left of my screen, somebody needs to go ahead and mute their microphone. Is that you, Dr. Shani? Oh, thank you. Okay, so if you remember up here in the top left of my screen, this module used to be called Rolodex. And to keep current, it is now named Patients. It makes a little bit more sense. So it is now named.
You're not seeing your screen.
They're not seeing my screen?
No, you need to share the screen. We're not seeing it.
Okay, I thought I did.
Did you go to the little box on the bottom that has a...
I did. So I'm sharing my application window.
I'm not
now?
seeing anything. No.
So how about now?
Nothing.
Okay.
You want to come use my room?
Hold on. Okay, so share application. Let me do my entire screen share. How's that?
Nothing yet.
Nothing's there now?
No. Are you in Axium?
Yes.
Let me see if I can go to Axium, see if I can share the screen up, then you can come up. Give me a minute.
Well, this should be, this is the share application screen, correct?
Yeah, but nothing's coming up. Let me see if I can share my application screen. If that's the case, come on up in my room and do this.
So this is not sharing?
No, I don't see anything.
Okay, let me run on up. Sorry about that, you guys. Give me about 5 minutes. I'll run up to Dr. Kashani's course or her office, and I'll be right up.
So let's see if I can share application. Share. Okay, I'm sharing. Come on up. Can you guys see? Okay, Dr. Bauer is going to come up so she can go through this with you guys in my room. So I'm just going to step sideways so she can get in here. Give us a few minutes. Sorry about that. Thank you very much. Okay, as long as you guys can hear me, we're good. Okay, mine is working. Come on. Sorry about that. I think it's the computer thing. Two of my computers don't work. This one does. Okay.
All right. So you have train up though?
Just put it.
Okay.
I have regular up.
I can't. I gotta be
Do you want training or regular? I have regular.
train. Okay, where's your?
And then go under your name and yeah. Okay.
Okay, where's your
Drag it to the right.
this? Is that sharing now? And how will you
No, no,
see?
no.
How can you log into another one to see your chat? Because I won't be able to tell.
Okay, then you have
Tap. And then minimize.
okay. Just go and share. I'll get into another. Yeah, you can see it. Go there. I can see the chat. You can also see the chat on the bottom. We're fine. Go. Put height. Okay. Drag this up. Now we can see the chat. Put it on the chat.
You'll have to.
Okay, you just do whatever you need to do. I mean, ask you to sign in so I can see the chats because you have to sign in because I can't sign in twice.
Okay, so if everybody can just give us a few more minutes, we're just going to get everything set up so that if you have any questions, so I'll go over all the changes in Axiom, but if you have any questions, Dr. Kashani will manage the chat so that I know when to stop. If you have a question, I can go over things. So just give us a few minutes. We're going to log in.
I just want to make sure you log in here.
Yeah.
Sorry about that. Let's see this one coming. Blackboard. Log in. Oh, I can't. You have to log into Blackboard.
Okay, Alexa, yes, I know this is a standard not met for time management. You are
Okay.
absolutely right. Or maybe
Sure.
this is a standard not met for the doctor not knowing how to use Collaborate. Can you go make a coffee? Only if you make one for me. I want it black, please.
Okay. Sign in because it's going to give me my sign in. Sign in here with your name. And don't ask for it to save it, please. Then I can find it.
You can find it fast as I can. Okay, so I think we're ready to go ahead and get going. Okay, so let's go over some of the changes. So some of the changes that occurred were pretty much cosmetic. So typically, I don't do an upgrade during the last semester of your senior year, but there were enough small changes that will help us to be more efficient. So that's why we wanted to do it. Then there's one additional change to a form that I think will make you guys really happy. This is courtesy of Dr. Gurin. So you can thank him for that. So I want to demonstrate what that's all about. But the first thing here, when you notice on my screen, you're going to see that this module up here that used to be called Rolodex is now called Patients. So Axiom really is just trying to make the modules mean something with the description and more modern. So now it's Patients. Most people really didn't know what the Rolodex was or is. So you're going to find it really runs the same as what it had done before for you. It just has a different title. Now, a number of students had asked me to make some changes in Scheduler. So typically when you log into Scheduler, the first window that opens is the Chair tab. So we've actually removed that for you so that when you open into Scheduler, you'll actually see the Active tab. Now, Active tab is your daily tab. So this is actually a very important screen to be in. And you see this is my schedule for today. If you want to look at the weekly schedule, you can, again, look at it by just clicking on the weekly tab. Now, some of you may want to see the chair view. If you need to see the chair view, you can either work with your PCC, PSA, or you can go to the operatory monitors and actually see what the clinic layout looks like. There are a number of you that when you go into the blue clinic, there's about a pair in each group that did not have an assigned chair. You now do. So you may have noticed that you are now assigned to, if you were in a virtual chair, you are now assigned to the Hygiene 1 chair. Chairs 2 and 3 have been taped off just to give a little bit of privacy between the dental side and the hygiene side. So I'm going to ask you, please don't go to the hygiene chairs. Chair 1 is where you will be located if you were the pair that did not have a chair when you were assigned in the blue clinic. One of the other new features, which is really nice, is now we can actually delete a perio chart. So if you do need to delete a perio chart, the ones that we will actually delete would be ones where you, by error, make a duplicate in the same chart. The other ones that we would delete are ones that are entered into the wrong chart. So if you actually have a perio chart, let's say you've completed one, but it hasn't been approved by faculty, patient's not coming back, and you now need to graduate. What you will do is you will still approve it as incomplete as we normally have. Let me open up my screen here. It's just going a little slow this morning. So you'll approve it as incomplete. Oh, I'm sorry, I'm looking at the wrong screen. Dr. Kishani is looking at your duplicate.
You have to take it to the right screen to see it.
So, so what you would do, you'd click on it as you normally would, edit, and then approve it as incomplete. Now, all of you are comfortable approving your perio charts as complete, the older way, and this is the way we need you to approve all perio charts. We have discovered that there is a little bit of a bug in Axiom as far as approving the perio chart, so I'll talk about that when I discuss the patient approvals window. But this is where I want you to approve the perio chart as complete. So make sure you're in the perio module or at the EHR perio tab. Okay, so another change that is actually very nice is the patient approvals window. So when we did the last upgrade, Axiom had tried to make the approvals a little bit more streamlined. So when you clicked on the blue box, you would see all the items that you had entered in on the day of that would require approval. But what they did is they had another window here that you had to click on Show Criteria to open up the filters. So they removed that window. So now you're just going to go into the patient approvals window with the filters. So again, if you don't fully understand the filters, it's a good idea to click on All Dates, because today these are the treatments that I put in that require approval. If I don't click on All Dates, you see how I can miss a lot of items. So I think, you know, as seniors, you guys figure this out real fast, but what I would encourage you to do is help your faculty. They don't know Axiom as well as you do. So just make sure you click on All Dates and then select everything that you want to approve there. All users would be important if you are in oral surgery, the faculty is sitting at the computer, you shared a case with a classmate. Switching to all users would help them find all of the codes that they have to approve by provider. So I will be discussing that again with them this afternoon, but if you happen to notice faculty struggling a little bit, help them out on that one. So no. So Allison, thank you for bringing that question up in the chat. Can you approve the perio chart in the blue box? I'm going to ask you to, there's two things I do not want you to approve here. I do not want you to approve the lab order. That's normally done by Dr. Kashani, Dr. Gurn, and Dr. Saunders, and I know they don't come here for this. The other thing I do not want you to approve here is the periodontal chart. And the reason being is, let me do a demonstration on that.
It shows as an incomplete. We don't have it.
Here we go. So I had to find my initial exam. So if I click on to approve, what it's going to show, see how it shows us incomplete right here? This is the little glitchy thing that we have noticed, and we've reported this to Exxon, and I was hoping that they would fix it by the time we did this upgrade, but I noticed that they did not. And there's no way that you can actually click on the word complete. So what I'm going to be doing is showing this to the faculty this afternoon and saying, please do not approve it this way. I'm going to ask them to cancel out and then go back into the traditional way, either the EHR, Perio tab, or the Perio chart module. Okay, so again, please don't approve them here because they will show as incomplete. To us, incomplete means that, let's say you completed a perio chart with one faculty, they didn't get an opportunity to approve the perio chart, so another faculty has to approve it. That's one way of approving it as incomplete. The other is if you started it, patient has left, and we have not been able to confirm the findings, but we want to keep the information that you have. We will approve that as incomplete. But completed means you started with a faculty member, they checked your findings, and everything is accurate. So that's the difference, and we want to maintain that. So one of the things, if you noticed, that we asked you to send us an email if you need any changes to, say, MyPacs, or if you need a note deleted. If you need a perio chart deleted, I'm also going to ask that you send me an Axium message. Now, right now, the deletions are a hard delete, which means if I delete something, it's permanent. There's no way I can go into the database and find that information. It's very similar to our forms. So that's why we restrict certain things. So I sent everybody a message yesterday. Here are the templates I'd like you to copy and put into your Scratchpad. This was all on the message that I sent you yesterday through Messenger. So again, this is the unapproved MyPacs, delete MyPacs. We also have a new one now. There's a note deletion, and then here's the one for the perio chart deletion. So before I do a deletion, I need to know specifically what needs to be deleted. Sometimes it gets a little confusing for us. So that's why we're asking you to use these templates. So please make sure you go ahead and copy this into your Scratchpad, and whenever you need to have something corrected, send me an email. Okay, any questions on any of that? Okay, another nice change, I think Dr. Kashani is really going to like this one, is that if you remember our stale dated treatments, our treatments that had the P and then you see a little asterisk right to the right of it, top right corner, those are treatments that we marked as stale or they had expired. So whenever you have a treatment plan that the patient has signed, 14 months after that date of signature, that treatment expires. That means you can't do anything with that code. You can't move that code to in process or complete. It's no longer a valid code because a lot of times your treatment can change. So we stale dated those treatments after a certain period of time. Well, when we did that, whenever we add some treatments, they show up in your odontogram. And so if you want to do an MOD on number 4 and you're planning to do it, it would have those little yellow dots there showing that you have treatment that needed to be done. Well, if we had stale dated treatment, we had to delete it actually from the TX history, or it will not fall off of this odontogram. Okay, the odontogram that shows in the in progress tab or the TX history tab. But now Axium has corrected that. So if there is any treatments that are stale dated on this list, it will not show on the diagram. or this odonogram. So let me show you what I mean by that. So here's a treatment plan from 2015. Now let's look at this. Let's look at this odonogram. See how there's like there's amalgams here. You see the little yellow dot. So here I have a 3DO that was still planned, a number of 2 occlusal that is still planned. And if you notice, that is still dated. It's showing on this odonogram, but not on this odonogram. So that was the big change. So now you really do not have to have any stale dated treatments deleted because they will delete but not show on the odonogram.
Makes the chart cleaner.
So yes, it makes the chart cleaner. It makes Dr. Kashani's life happier. It makes the life of your CL very happy. Now, because of that, we changed the views over here to the right to make them a little bit easier to understand. So you know conditions and materials. We have the P&I treatment. This used to have the little asterisk with the stale dated. You no longer have to see that. So it's still in the background. You just don't have to do anything with it. We have the codes in the notes. We have the notes and completed codes. So I just renamed those to make them a little bit more understanding and easy to use. So I still would suggest that when you are doing a new POE or a new exam and you have older treatments on your list right here, have faculty remove them. If you don't, they'll stale date at 14 months from the signature on the treatment plan, which would be fine. But if you actually delete them out, you won't get confused if you duplicate a treatment. So I would recommend you see that. So we can no longer see any stale dated treatments in the P&I tab at all because P&I treatment, well, I hid it because you don't need to worry about the stale dated. So you won't see it at all. Could you approve? I think I've answered any question. I think I've answered them all. Okay, got it. All right, thanks, yeah. Lucas. Okay, so good questions. So now the next thing, there have been some form changes. Now, I did mention to you all in an email that I changed the name of this health history form new because it really doesn't describe what it is. So we have the child health history, which is for the child under the age of 14. Once they become 14, you actually complete what we now are calling the adult health history. So here, this form will not change the name if it's already into the chart. I'm going to see if we can actually change that name. So if you happen to notice over a period of time that you no longer see this description, it's because we were able to actually change that to now the adult health history form. But if you do pull a brand new one and your new patients, like you screen a patient, you're going to open up a health history, it will now be the adult health history. Same location as this one on the list, because all I did is change the title. So it'll be in this about 2/3 of the way down. So that's somewhat of a minor change. But the next one is something that I think, like I said, I think you'll all be very happy. We now have a new CARES risk assessment form. If you recall, the old form has 3 tabs. The first tab was the diet risk. Then you went through, the assessment of the patient. And then the third tab, most of us didn't use because it was confusing on how to use it. Well, the CARES risk form is now very simple to use. So the old one has been inactivated. So if any of you had an unapproved CARES risk assessment form, we have suspended all those. So those should not show up on your unapproved. If they do, send me an email and let me know, but you should not see any of those at all. So I want to go ahead and demonstrate the new form. So we're just going to go ahead and open one up. It's again, same title, CARES risk assessment. And now you're going to see, this is it. Okay, now there is a calculation. You can see the calculate button right here and also this little function there. So you're going to ask the patient these top questions, which are the CARES risk factors, and then you're going to look at the disease indicators. And this is through your clinical exam. So these are all yes or no questions. Okay, and then there's a calculate based on these yes or no answers right here. And then we have a few other details. And so let me show you what they are first. So basically, if the patient has all no answers to the CARES risk and the disease indicators, that means that they are a low risk. If they have any yeses down here on the disease indicators, that's an automatic high risk. If this is no, but up here on the risk factors, there's a yes, that's moderate. So let's go ahead and go through all these, and I'm going to put mine as a no. So here we want to know if the patient has dry mouth. You would ask them that. You'd ask the patient if they have any medications causing xerostomia, such as hypertensive medications and the rest that actually cause xerostomia. So for example, if a patient who is on, say, Synthroid, that does not cause xerostomia. So the answer would be no to that question. And you're going to ask about smoking, if they drink anything other than water throughout the day and between meals. Do they snack? Do they get plaque buildup? So in my patient, they're going to have no for all the risk factors. But now we're going to look at our exam. And let's say if I see a new cavitation, I'm going to click yes, and maybe the rest of these are no. I don't see any radiolucencies, and there's no new lesions. And then you're going to look at the decay history if that's a concern. So this would be an example if a patient has recently had any teeth extracted or restored due to caries, say within the last year or so. You might have a decay history as being a concern. So in mine, I'm going to say no. So here I filled out all my questions. As you can see, they're very simple, yes, no. And then you can either double click here on the question, do the calculate, or come down here to the bottom and click on calculate. And so it's going to tell you it's a high risk based on the answers to the questions above. But like I said, any yes answers down here, it's an automatic high risk. Everything is no, it's low. A yes up here and an all no's down here is moderate. Then the next thing is this is a caries management. We want to know, how are you going to manage this patient? So here, for example, with a high caries risk, you might want to put them on a xylitol product, Prevident, or a hygiene instructions and a recall. And so I'm going to, you want me to type something?
No. I said they have to type it.
Yeah, you have to type this in. So I'm going to kind of leave this blank, but I can give you the examples of what you can put in there. And then you're going to determine the caries recall. If you notice, I have a key here for you in case you are not sure. So mine is going to be a 4-month recall. Now, you posted Dr. Kashani posted the format of this form in Blackboard, so you can look at that in a little bit more detail.
I'll do it by the end of the day. I don't think.
Okay, so it'll be loaded by the end of the day. But the thing what I wanted to point out is this 4-month is really important to us. This is how we're going to track when the next caries recall will be done. So again, use the key here. It's pretty straightforward, and then put this in. So that was the calculate portion of this form. So upon approval, the nice thing what this form will do, there's a trigger that will actually enter in the code for you as far as the caries risk. So you know the D0601 that you were supposed to add if it was low, then the 2 and the 3. Most of you may have been forgetting to enter that in and losing out on your CPUs there. So now this form will actually do it for you. Couple of things, though, I would remind you of. The way the trigger works, whoever is the last person who made an adjustment on this form will be the provider on the code. And if this is a faculty member who logs in and makes a change, they will be the provider. And since they're not a provider, it leaves the provider blank. And I'll show you what I mean by that after I go ahead and I approve this.
Let's see if I can upload it.
Okay, so let me go ahead and approve. This is the normal approval. Now, one thing about this trigger, there's going to be a delay of 15 seconds. So here I wanted to click on the approve button again. Don't do that. There is a 15-second delay. So you just got to be patient on this. So once it drops down, you'll be able to now find in TX history. TX history plan. It's now under the completed code. You can see here I am, the D0603 as completed. Now, if this becomes blank, I think you guys all remember how to go ahead, double click on this, and you can then put in your provider number here. Okay, so I want you to make sure that you go ahead and do that.
Without a provider anyway.
It
won't let you approve it without a provider.
Yeah. So if you happen to notice it's blank, just double click on the code and then put in your provider number. Or if it was your partner who actually did the form, the bulk of the form, you can change that out.
Tell them the caries risk form is Under content in the oral diagnosis form.
Okay, so Dr. Kashani has just uploaded the CARES risk form under the
For what? Under content
content
and oral diagnosis folder.
in the oral diagnosis folder. Okay, what is the CARES risk recall? So in the past, the CARES risk recall used to, we would do the recall at each POE. So you'd complete the 2400, and in theory, you were actually supposed to bring this person in, review their carries, if they had any new activity, and it was meant to be on a regular basis, depending on what the CARES risk status was. Unfortunately, we really got away from doing that.
That was the third page one we used.
Yeah, it's the third page of the old form that we never used. So now this is actually going to help you. So what you're going to find, so this patient is high risk, so they're due for a recall in 4 months. So that means you're going to bring them in, maybe you're doing a restoration, you're going to then check the rest of the mouth to see if there's been any changes. So a change would be like a new cavity, that type of thing. So that's what you're looking at.
And I think you answered Lucas' question. So CARES risk, does it go as a P or a C? It looks like it went in as a C.
No, the carries. So Lucas, you do not have to plan it as we did before. So the really cool thing about this trigger, it's going to move it to complete for you, but you do have that 15-second delay. So the way I look at it, it would take you 15 seconds to add it as planned, then another 15 seconds or longer for the faculty to approve it. Then you had to remember to move it as completed, which a lot of you forgot to do. So for me, I think this trigger actually is really great. So just remember, it's a 15-second delay and it moves it right here to completed for you. Okay, so remember when I was in the planned, I was here and go, oh wait, it's not there? That's right, because it goes to the completed codes. That's where you would see it.
Ashitari says, do we need to take radiographs for what?
So if you're looking at a patient for CARES risk, you're typically going to look at the patient to determine if you need radiographs. So if you saw major changes, you might want to consider taking radiographs. But really, if you already have radiographs that show the caries, you may not need to take new radiographs. A lot of times, like you might find where a patient had a white lesion that actually now is cavitated. That would be like a new lesion. Okay, what happens if we click approve again and the fact, Kevin, I don't know what happens again. I did that and I think it just made the trigger think a little bit longer. So I found that when I did click on mine, it still added the code. It just took a little bit longer to think.
If
So
you added 2 codes, just contact me. I'll delete them.
and if it does add 2 codes, all you have to do is come over here, click on it, and click on the X to delete. Okay? Any other questions on that? So I'm hoping that you guys will really like this. So, I think this is a big change. So again, I would say, hey, thank you, Dr. Gurin. This is a really cool form, saves you a lot of time. And this is really something more of like what you'll be doing in your private practices. Okay. So now one of the things I want to go up here is to the patient care and talk about the check-in form here for a second. So train is just working a little slow today. Okay, so you all know the patient check-in form. So this part right here with the CARES risk, what it would do, this was a calculation off of that old code, the completion of the 2400. Chuck will be working on actually reworking this part of the report to where it'll tell you what the CARES risk is, low, moderate, or high, when it was last done, and then if you're overdue or not. One of the things I have been noticing is that many of you are, when you're doing the start check, you're actually closing this check-in form right here and not allowing faculty to look at it. I want you to please stop doing that. This actually has to be checked by faculty at the start check. So I'll be going over that with faculty this afternoon. So please, again, like I said, do not close this out at the start check window. Okay, so we've also made some changes in our codes and in the quick list. So the office visit, the 9340, we find is being used inappropriately. So for example, let's say you had just restored an amalgam last week. You know, you charged the patient. Now the patient's back. You have to replace that amalgam because it broke. The tendency is to put in an office visit and have a no charge entered on the patient's account. What we actually want you to do is go ahead and plan that same amalgam code, replace it, but then see Dr. Gurn and Dr. Kashani for a fee waive. So we want a record to accurately represent what you did. Okay, another thing that we sometimes see is that if you want to do an adjustment on a denture or a partial and it's past the 1 month recall, there is a code that you can use for less than 6 months, but a lot of times we see that the office visit is being used. So you're missing out on some CPUs and things like that. And again, the chart is not being accurately reflected for what you're doing. So now, from now on, there will be a $20 fee for any office visits that you use. So because of that, we want to make sure that you are aware of the codes that you should be using. So we've updated the quick list, and we've made a few changes to the code. So I'm going to show you right here in TX history. You can also do this in TX plans. So I'll just show you the quick list. And by the way, you guys, I also put this into links under student how-to docs. It's all typed up to where you can see it, so that if you want to take a minute or two to look at it so you know what codes are available for you, it's this one called Quick List, the Common Treatment and Macro Codes. So again, I went to links, student how-to docs, and I went on the treatment planning folder. And so if you open this up, it will show you all of the codes typed out. So I'm going to minimize this here for a second. So here you go. Again, it's all by diagnostic codes first. You'll see the macro codes. We've added a few here: the office visit, missed appointment, canceled appointment, the patient came in but nothing happened. So a lot of this you see, I actually rewrote this a little bit to get you comfortable with the code and then the description. So some of this is very similar. So as I scroll through, there are some changes though. So for example, the ones with all the adjustments. So the way the ADA changed the codes a couple of years back is anytime you do an adjustment now, say on a denture, it's by arch. So it's a maxillary versus mandibular. It used to be combined, but they separated it out. So what we did is we added a 0.1 code so that you can do an adjustment for less than 6 months. This would be an interim or definitive. Now, the reason why we did this is normally it's considered the norm when you deliver a denture or a partial, you do the adjustments for up to 6 months. After that, there's a charge for it. So if it was less than 6 months, this is the code you would use for the dentures. And then here's the 2 for the partials. Now, one of the leads actually asked me a question about how do you do an adjustment on a denture that you just did a reline for? Any change you make to that denture, such as adding a clasp to a partial, adding a tooth to a denture or to a partial, or doing a reline, you can, and you need to do an adjustment, you would use the code less than 6 months. Typically, there's no fee for that. So just be aware, those are the codes you would use. We've also added to the quick list the repair of a broken denture base, repairing teeth, adding a class. So sometimes you don't know what code to use. So we put the commonly used ones onto the quick list so that if you're not sure, come here and look first. Most likely it's going to be here. Also, if you're putting a denture or partial through the ultrasonic, there actually are codes for that. Here's for sectioning a bridge. So if you weren't sure which code it is, it's right here. Here's re-cementing, rebonding, a fixed bridge. So again, I think you'll find that there's more codes that have been added. We've added the extractions. And this one, and I must not have updated this, I actually put the alveoloplasty here when you're doing an extraction. That's a commonly used code that many of you are forgetting to use. We also have nitrous. It's under miscellaneous. It's not on this form, but it is in real Axium. So again, I would suggest looking at this list first. You know, you can always do a search if you want to. Sometimes what I'm finding when you do the search, if you're not familiar with the codes, you might be using the wrong code. Okay, so if the patient needs a reline less than 6 months, is there no fee? Well, you would charge for the reline. Well, it depends. That's kind of a question. For example, if you're doing an interim, we typically do a soft tissue and there is a fee for that. If you're doing, let's say we delivered a denture and let's say, for example, you're finding that it doesn't fit and you want to do a hard reline, normally you're going to put in the code, but see Dr. Kashani and Dr. Gurn and discuss with them whether or not you should do a fee waive. Okay, so, but yes, so Kevin, that's a good question, but typically, yes, a reline, you do charge for that. The adjustments typically no up to 6 months after the reline. Okay, so excellent question. Okay, so
code for occlusal adjustment or fillings or crown recementation. There is a code for crown recementation.
yes. So this one is a little tricky. So I showed you the one for the bridge, re-cement, rebond. So you asked actually a really good question. If you, depending on what you put in the search box, I think you guys have all figured this out. Sometimes nothing comes up. So you have to put in the right words for the search to work. So here's a remove crown, and here's the re-cement, rebond a crown.
Yeah.
So it's the D2920. So good question. Is there a code for occlusal adjustments on fillings or crowns re-cement or on just
There's an occlusal adjustment, but there's a fee for it. You don't do that.
The occlusal adjustment that is actually done on enamel is a little different. If you had to polish this down, I would probably use our internal code, the 1400, which is polishing. It means adjusting or polishing an existing restoration. So I would suggest that. And I can actually throw it in here. I did not. But if you guys actually find some codes that you think are commonly used or codes that are challenging for you to find, let me know and I'll put them onto the list. So the whole point is for you guys to let us know what would help you and then the students as they come through. Okay, so yeah, just send me an email and let me know.
Not about the 9430. 9430.
Okay, so just as a reminder, you guys, the 9430, if you use that, there will be a $20 fee and that will not be fee waived. So I would suggest if you do not know what code to use and you cannot find something off of the list, work with your group lead. If you still have a question, I probably would go and ask Dr. Kashani or Dr. Gurin, or if you find me, I can help you as well. But typically, there's almost always a code for what you're trying to accomplish. Okay, so I want to go over now a few other options or problems that we're seeing. So we get quite a few insurance rejections for items that, to me, I think at this point in time, you guys should all know how to do.
It says there's a fee assigned to it. Do we have to have the patient sign for it? I'm not sure if anybody was going to pay for the office visit, but it's an exam now.
No. So where's that question?
The question is Swanee.
Okay, so not with that one. Usually when a patient comes in for like a screening or for the 150, we don't sign for that. They know, you tell them, yes, this is the fee associated with it. But see, I don't anticipate that you would be using the office visit. You really should not be using that. So just to discourage you from using it and to actually use the appropriate code, like what you're going to be doing when you go to private practice, we put a fee to it. So again, we find that that is the catch-all. So instead of trying to find the appropriate code, you're using, the 9430 or 9340, which is the office visit. And again, in your office, you guys, you are not going to use this. If you do a denture adjustment, you use a denture adjustment. But actually, you asked a really good question that I do want to remind you that we're starting to see anytime you change something on the treatment plan, let's say, for example, that 4MO becomes a 4MOD, you will now add that treatment in chart history or chart add, get it approved, get it star checked, and have your partner or you go see your PSA to get the financial agreement filled out to have the patient sign before they leave. We see that you guys are not doing that. So what happens there, a patient can come and challenge that. They can say, I never signed for this, so I'm not paying for it. And we've had a lot of problems with that. So I want you guys, please make sure you actually go ahead and get that financial agreement. Now, I'm not saying stop everything. No, you have a partner, or maybe you have a friend next door in the next cubicle who's not doing anything. let them go and get the PSA so they can go ahead and start the paperwork. It's not meant to slow you down, but it's meant to protect you. Okay.
10 minutes.
So Lucas, send me that email. Your question, send me that email.
He wants to know if we can use, yeah. Don't put a 330-2, put a 330-1.
Let me look into that, okay, Lucas? But send me an Axium message if you wouldn't mind, because sometimes I forget. So the other issues, and I only have a few minutes, so we got to get going. I want to show you another issue that we have a problem with. And as you guys look at this treatment plan, please tell me what's wrong. Okay, I just had one of these come in. So here is a treatment plan for a denture. What is wrong right here, you guys? Please don't do that. Again, this is in your life, your career. If you put in the wrong diagnosis, your insurance will not cover this. You don't do an extraction because of high risk for dental caries. You get that rejected. So please make sure you don't do that. So a couple of things that will be coming, just to give you a heads up. And this is more or less to help you when you go into your practices. There's going to be another tab added here, which is called dental devices. And this is how we will be tracking implants that are placed, bone and membrane that are placed in the patient's mouth. So for many of you, you're going to graduate and you yourselves might be placing implants. Well, you actually have to track the lot number, the serial code, the manufacturer, and the date in case there is a recall. So many offices do this on an Excel word sheet, or they do it manually. And we've been doing it manually for a long time. Now we're going to have this little module to where we can actually scan the barcode and it's going to fill out all the information on a form for us. So you may have read access to it, but if you happen to know what it is, it's a good idea on a patient who has an implant to go in there and look so you can see what we actually have to track. Because like I said, if you yourself, once you graduate and you're out in practice, you place implants, you will have to do the same thing. You may not do it this way, but you do have to track the placement of the implant. And the last thing is the state of Michigan has approved that we do have to go to electronic prescribing of all prescriptions. So the reason why I bring this up is that we will be transitioning as a school to electronic prescribing. This will not affect you here at the dental school until you graduate. You will still be doing prescriptions the regular way. But just remember, once you leave here, the drop dead date is in October of this year to where everything must be electronically prescribed. So there's no more written prescriptions. So just realize that that is coming for your generation. Actually, when you graduate in October, be ready for it. So if you guys do notice any problems with the upgrade, I will be in the training room most of the morning tomorrow. And but if there are any problems, get a hold of your lead. They'll usually text me, but I'll come down first thing in the morning. But let me know if you notice anything that's not working quite as well as it should. Okay. I don't think I see any more questions, so I think we finished with enough time.
And Dr. Abuze should be coming in about 7 minutes. I'm just texting him right now, so you have a few minutes of rest before he comes in.
Yep. So if all you guys heard that, you have about 7 minutes. So if anybody wants to go get that coffee, bring me a black one. What do you like, Dr. Kashani?
I like my tea.
Dr. Kashani wants some green tea. Okay, but like I said, you guys send me any messages. Yep. Thanks, Alexandria. If you see anything or have any questions, I'll take note of it and try to make some changes there. So Lucas, I will look into that code.
I just stop sharing and then we need to stop recording. And then okay, corner says stop recording. The little the little right there, right there. Do you see the little square with the red in the middle of it? With the 3 bars? No. Down on the block. Yeah, right there.
Are we done?
Yeah, it says recording progress. We have to stop recording. Let me do this. Okay. Oh, I'm sorry. You said you can't hear me. So I'm so sorry. We turned ourselves off. The CPU code is per code. And for the medication, put down the information of what you need for the medication. I gave you 2 medication on a piece of paper. I do not want you to print out and bring it in there because imagine tearing up 1 sheet and then again imagine tearing up 20 sheets. I don't want to have that. And so whatever you need should be on that 1 sheet, one side of the sheet. You need to know the drugs and the interaction of those drugs that the dentist prescribe, not 20 pages of the drugs that is on the drug. So what you did in the competency, what you enter into the axiom, not into the detail that you enter into the axiom. I don't know why you can't hear me. We can't hear you. So in normal size paper, whatever paper you bring, it has to be torn up. Can you guys hear me? Okay, just want to make sure. I thought it was loud enough. Yeah, I do not want to have pages and pages and pages of paper in front of you. That's not the point. Do you want to know the interact, or you can put the name of the drugs and you can make like little notation on the side that decreases activity, increases absorption, whatever. That's enough. You don't need more than that. I do not want to know about category C. I don't want to know about the management on that medication. I'm going to ask you some questions on the case that you have to answer, but I do not want you to write all of those down unless you think you want to write it small. I'm sure you guys can write pretty small on that paper. Yeah, you can come in with the drug info on a paper, yes. I believe I put in 180 minutes. That's 3 hours. I don't think you need 180 minutes, but you can have 180 minutes. I am afraid about a regular size paper because I'm not sure what's going to get on it. Half of the size of the paper is plenty, because if you're going to write a diagnostic summary, you're not going to write it on a paper and then upload it. Diagnostic summary, can we put whatever we want on that paper? I'm not sure what you mean, what you want on that paper. I gave you 2 drugs. That's the only thing that should be on that paper, nothing more. By the way, I'm not asking you to write down ADA codes for me, so don't think about, oh my God, I don't know my ADA codes. It's about writing the treatment plan, MOD, amalgam, extraction, whatever, and sequence and phasing, but I'm not going to ever ask you ADA code on that kind of an exam. Yes, if you use it on Notepad, it's okay to use it. Yes, you can use it. Yeah. Yes, yeah, it's the same formatting. And also there is a video that says how to make a table. Make sure you make a table. I want to be everything on a table when you put a treatment plan. Do not do funny things, please. The video is right on top of the exam, was the first item on the list. And I asked Evan Goodell to check it. He said it's about the same. It hasn't changed. We're waiting for Dr. Zayed to get in there. I just sent him a text. So I'm going to go into a silent mode for a while. Make sure that he's coming in. Thank you very much, you guys. Take a few minutes.